I'm a good friend.
All righty.
Sean, you and TJ are in charge.
Okay, so I'm just gonna start by saying, so this is as the email said. I guess, did we already say what the reason for the case was in the email? Does everyone know?
But they might not have read the email, so go
okay.
We'll figure it out when you put the numbers up. We'll figure it out.
Yeah. So I wanted to start by saying I got this case from Dr. Judd when he was my attending on renal consults. So if you've had him on renal consults, you may already be familiar with this case. I just thought it was a great learning point, and I asked him for permission to share this case on this platform.
So Eric, who is also one of my former residents, did a wonderful unRemarkable labs on urinalysis, looking at the microscopic urine. So for those people who were here that day, he's really an extremely intelligent, thoughtful nephrologist. So if you got it from him, I'm sure that it's going to trick me.
So this is the case of a 26-year-old male who was admitted a week prior for a left craniotomy, temporal lobectomy, because he was having seizures that were refractory to his medications.
So we're going to see him on the neurosurgery service.
You got it. And we're being consulted for hyponatremia.
Okay, let's just stop right there. So how could this surgery have anything to do with hyponatremia? Sabina, you had volunteered to go first, and so we'll let you start, and then Kiara will kick in.
So kind of my first thoughts when I hear anything related to the brain and hyponatremia is I kind of anchor in cerebral salt wasting, which is actually a little bit rare. But the other things that you could think of on the hypotonic side are hypotonic hyponatremia, are anything related to adrenal insufficiency, hypothyroidism, if something was affected near the pituitary gland. Those are kind of my initial thoughts. I think it also, if somebody has had some kind of, if they were hyponatremic, got mannitol for whatever reason, that could give you like a pseudo hyponatremia. Those are just kind of my initial thoughts hearing that.
Do you have any other thoughts, Kiara?
Well, yes, just two things. One, the most common I will be thinking is some kind of CHAT, which with some manipulation on the temporal lobe, this could be leading further to a CHAT, and with that extra ADH secretion, and with that hyponatremia. And other thing is how long was this patient hospitalized, and how was her fluid management, maybe something like this.
So the two of you have come up with a really, really good schema before you even see the patient. And that's actually really good. If you're going to do a consult and they say, we want you to see hyponatremia in this guy who had surgery a week ago, this will sort of direct some of the things that you'll think about in terms of trying to evaluate him. I love that you talked about SIDH. Anytime you muck around with the brain, whether it's an infection doing something to the brain, it's a tumor doing something to the brain, it's a bleed doing something to the brain, or a surgeon doing something to the brain, ADH might be released. And so that's high. I was interested, Sabina, you talked about cerebral salt wasting, and that's really sort of controversial these days. Is there such a thing as cerebral salt wasting, and how does it cause hyponatremia? So we'll see whether or not we get anything that gives us that information. I love that you thought about, okay, even though it's the temporal lobe, could they have slid over to the pituitary and messed things up and gotten pituitary adrenal insufficiency or pituitary hypothyroidism? I think it's a little quick for hypothyroidism, And remember, hypothyroidism, according to many nephrologists, and I see this on Twitter all the time, there's a debate over whether it really causes hyponatremia. Now, I did have a patient who I'm pretty sure had hyponatremia from hypothyroidism, but he also had an empyema, so maybe he was from the empyema. But adrenal insufficiency could happen really quickly if you knock out the pituitary. So that's good. Had they changed his anti-epileptic medication, and how is that going to do it? Sabina, could you just clarify what your thought process is here, just so we'll understand how to think about this?
I'm just kind of thinking of the first things that kind of spring to mind. It's not really organized, I think, but it's a very valid point, SIADH, and different types of anti-epileptic drugs like valproic acid, Depakote. I'm not 100% sure which ones of those cause hyponatremia. I usually think of like Zoloft, antipsychotic drugs causing it, which I don't think would be as applicable in this case. It's just kind of the first things that I thought of.
Well, no, I agree 100% that there are anti-epileptics, and I think the chat is going a bit of looking at that some, but a number of neuroactive drugs can cause ADH release. The question is, he was admitted for the meds not working, and so if you stop the meds, that I don't see how that would help unless they increase the meds, and so we'll have to get more of the story there. So let's see what's going on, and then we'll come up with a way to systematically go through this and try to get to the right place. Great start.
Yeah, that was incredible. Great. A lot of really great thoughts there. So a little bit about kind of his past history. He had a TBI from a jet ski accident at age 10. Involved his left frontal region, had a skull fracture, left frontal hemorrhage.
Just for our international friends, TBI is traumatic brain injury.
Yes. And that required surgical repair at that time. He's had seizures since the age of 13, both reportedly partial and generalized tonic-clonic. And for Dr. Centaur, he has a baseline normal renal function.
Okay. Might as well see what the numbers look like. This is about the numbers, and then we'll go back and do physical exam and stuff like that. But we got called for the numbers. You got called for the numbers. Let's see what the numbers are.
Yeah. And I hope I'm not disappointing you, Dr. Centaur. I actually don't have all like the numbers that fill in every blank, but I have all the numbers that are needed to make the diagnosis. So
okay,
that's what will be provided. So this set of labs was obtained shortly after shortly in the post-operative period when he was noted to be hyponatremic. So his serum sodium was 129. His serum osm was 268. His urine osm was 118. His urine sodium was 28. And he also had a UA at the time as well with his urine studies that had a specific gravity of 1.002. A pH of 9. And otherwise nothing to report.
So that's really, really interesting. That's really interesting. So Kiara, let's talk about, before we worry about the serum osms and the urine osms, let's go ahead and develop our process for working through a hyponatremia case. Now, the good thing here is that 129 is not a dangerous number. it doesn't really get dangerous until it gets below 125. Now, that doesn't mean that the patient's not symptomatic.
Mhm.
The patient could be symptomatic. When you do outpatient medicine, for years I was taught about asymptomatic hyponatremia. Don't worry, the sodium is 128. Don't worry. Do you have any idea what the danger is of having sodium 128 if you're an outpatient?
So, as you said, we have kind of a limit of 125, and with that we can say that it's going like to severe hyponatremia. However, I know that there is some sort of chronic hyponatremia, which fewer levels of sodium maybe won't cause any symptoms for a patient. So Afdidis immediately post-op patient with
So,
129.
Kiara,
Yeah,
slow down. Slow
yeah,
down, slow down.
yeah.
Okay, because I think you didn't understand my question.
Oh,
So
maybe
you're in
not.
clinic. You're in clinic. This is not our
Yes.
patient. This is a different patient. So you put
Okay.
a patient on thiazide or an SSRI, and they come in and they have a sodium of 128, and they say they feel fine. Should you worry about that? And let's say it's a 75-year-old woman.
Maybe if this patient is not asymptomatic, I may check on her volume status and not be so aggressive.
So you're about to learn something.
Uncorrected.
Learning is
Okay.
about to occur because we found something they didn't teach you. That doesn't mean you did anything wrong. They didn't teach you this. Sabina, have you been taught this?
Yeah, it's pretty bad on the bones. These, especially elderly patients, tend to get osteoporosis and fractures more easily with low sodium. I don't know the exact mechanism of that though.
But there's another bigger risk. So here you're about to learn something. One of the people who really taught me a lot about teaching said that if you're feeling a little bit uneasy right now, learning is about to occur. Anything less than about 132 increases your risk of falls, an odds ratio of about 65, which is a ridiculously high odds ratio. And it does it for two reasons. You have decreased ability to maintain short-term memory and remember what you're doing. And it has an impact on gait. And this is very well documented in the geriatric literature. And it's called so-called asymptomatic hyponatremia. So when TJ has a patient in clinic and he puts them on an SSRI and they come back with a sodium of 129, but they say they feel fine and their depression is actually better, that doesn't mean that there's not a problem. And so this is are you willing to take the risk of a fall for the benefit that you're getting in terms of the depression? So that's just something to keep in mind. When I say 129 is not dangerous, we're not going to get major neurological findings in the short run. We're not going to get seizures. We're not going to get major altered mental status. And there's one severe hyponatremia has one other potentially deadly symptom other than that. This is anybody who can give this to me in the chat wins a Centaur Pimp brownie point. Those are worth nothing, by the way. So patient could die if you don't make this diagnosis from severe hyponatremia. And the treatment for this is 3% normal saline. And that's a paradoxical treatment. Now, we already mentioned seizures, Kashal. Good. So you're about to learn something, and I learned this from being at a talk at ACP about 7 or 8 years ago, and that is neurogenic pulmonary edema. So you can get acute pulmonary edema from severe hyponatremia, not cardiac related, and the treatment paradoxically is to give 3% normal saline. So if you have someone with pulmonary edema and severe hyponatremia, just remember that may be causing it. And when I learned that, I said, I got to teach that to everybody that I get a chance. Okay, so the first step, let's go back to our patient. The first step with the sodium of 129, they accomplished the first step. What was the first step, Kiara?
I'm sorry. First step when approaching this patient, you mean?
The first step in evaluating that sodium of 129.
First, immediate symptoms. Maybe this isn't a symptomatic patient.
Patient's not symptomatic.
Patient's
It's
not
just that we're
symptomatic.
trying to figure out why the patient has a sodium of 129 so that it doesn't go any lower.
Can I go to the serum osmolarity and all of this?
Yeah, absolutely. So
Okay.
why is the serum osmolarity so important?
So I know that there are three key important data that will help us to know why is this cause of this hyponatremia. One is the serum osmolarity or plasma osmolarity, then is the urine osmolarity, and then is
So
the
let's hold off on the urine osmolarity. Okay, so
yes.
I have you confused, and it's probably the way I'm asking the questions. But the first step is to prove that it's really hyponatremia.
Yeah, so we are in a scenario of a real hyponatremia because the
Right.
osmolarity is less than 275.
Right. Yeah. So, and one of the things we had to worry about, and I think Sabina mentioned this, could this have been pseudo-hyponatremia because a lot of times neurosurgery patients get mannitol.
Yeah, many too.
And so this excludes mannitol as the cause for the sodium of 129.
Yeah,
We
or
don't even have to
maybe
look at the chart. Now,
yeah.
we'd look at the chart, but we don't even have to look at the chart. So step number one, is it real? Yeah, it's real.
Yes.
Step number two is what, Sabina, what's the normal step number two?
Volume
in your
status.
mind?
Volume status.
Right. And it's going to be really hard to tell in someone who's post-op. In my mind, in 2021, I should learn to do this as an old guy, but definitely as a young person, you should definitely learn how to do enough bedside ultrasound that you can estimate volume status. So you can at least tell is the patient volume contracted.
Yes.
You might be able to tell you can see if the patient has edema. I'm assuming that when you go to the bedside, this patient's relatively uvolemic. Is that true, TJ?
Yes.
Now, the reason I assume that is because the next step. So let's just assume uvolemia. So now you're getting ready to go to the next step, Kiara, which was what?
The urine osmolarity, you mean?
Yeah. So what do you make of that urine osmolarity? That's not what I expected.
I'm sorry?
I didn't expect a urine osm of 118 before I got there. When I heard this patient had 129 status post brain surgery, and the urine osms are 118, that sort of shocked me.
So we're in a probably in a uvolemic status.
So I think we can assume uvolemia. So how do you interpret that urine osm?
So after this urine osmolarity on 118 and urinary sodium of 28, we are I'm not so sure about the question. I'm sorry.
Okay. So let's see what Sabina has to say, and then
I mean I don't get the question. So
okay, well, Sabina, do you understand the question?
Yeah, my interpretation of urine osms isn't the best. My understanding, though, is that it seems a little bit, to me, it seems dilute because the lower limit of normal is 50 and then it can be concentrated up to 1200. So to me, that seems dilute. But I know when we're thinking SIADH, urine osms over 100 was one of the things that I was taught before. So not 100% certain on that there.
So
the UA is dilute, though. The UA specific gravity is 1.002. So that would kind of speak to being dilute.
That's pretty darn dilute. Okay, so let's talk about that for a minute. There was a debate this week about hyponatremia on Twitter, And the question is, what is the cutoff for dilute urine? The classic cutoff in the literature is 100. There are people that say you ought to go up to 150 or 200. The schema that was presented was like 285 was dilute. That clearly is not dilute. But this is awful close to 100. What can we infer from a urine osm of 118, Sabina?
So you're spilling water into the urine since it's pretty
Okay.
dilute, which means ADH is off. This isn't, well,
Okay.
ADH is on, sorry, backwards, since it should be pulling
Well,
water back up.
Okay. So this confuses the heck out of everybody. Every time we talk about renal physiology, it's like the majority of people's brains have little tiny seizures. Renal physiology gets really confusing. Let's define what a sodium of 129 and a serum osm of 268 mean. It means that the patient is waterlogged or overhydrated. The patient has too much water for its solute. So if that were true, if I gave you 3 liters of D5 and W and you didn't die, what would your urine look like?
Very clear, very dilute.
Very dilute, just like this. And so we can argue about whether 118 is technically dilute. Certainly, the specific gravity of 1.002, we know that's extraordinarily dilute. And so that means that the kidney is working exactly right. Does the urine sodium help us at all? And I don't know the answer to that question. So maybe TJ is going to teach that to us, that this should really help me. Let me tell you what I'm thinking. So there's not many osms in the urine. The urine sodium has to have an anion attached to it. And remember, the urine osms are the cations plus the anions. So we got about half of the urine osms right there, because 28 plus 28 would be 56 just from the sodium. So there must be some other cation in there. This is not salt wasting, clearly, because we don't have really high urine sodium. And so I don't think it helps me a whole lot, other than I don't think that I'm dealing with cerebral salt wasting. Now, how do we excrete a dilute urine? If I give you these 3 liters of D5 and W, how does your body, what is the signal to your kidney to totally dilute your urine?
ADH. So ADH must be off in this situation, I would think.
Right. So now ADH is either off as a secondary to the surgery, but usually when ADH is off secondary to the surgery, we see hypernatremia, right? So diabetes insipidus usually gives us hypernatremia. Are there any other, so how are we going to get to the sodium of 129 and the kidneys? We can assume the kidneys are acting appropriately, unless we flip over and develop hypernatremia afterwards. So if we need to look at the IV fluids and see how much water this patient is getting, and see whether the patient is getting dilute because they're getting too much water. Let's say we had an outpatient who came in and had a sodium of 129, or someone's admitted to your service and they have a sodium of 129, they look uvolemic. What are the main causes we think of for having a dilute urine and hyponatremia on a patient admitted to our service?
Me, maybe?
Sure.
Okay, so
There's three big categories.
yeah, you asked for uvolemic, right?
So you're euvolemic, you have a low
Hyponatremia.
sodium, and you have a low
Yeah.
urinosum.
So first on my mind is some sort of ADH secretion, maybe for CHAD, or maybe some ectopic ADH
No, because
secretion.
ADH is going to give you a high
Um,
urinosum. If you have a
oh,
low urinosum, ADH has to be
confusing.
suppressed.
Well, yeah. Mm,
So this is a really hard question. Most people haven't thought this through. Sabina, have you thought this through?
Psychogenic polydipsia is the first one I'd think of. I think
Right,
beer
and apparently we're not supposed to say psychogenic polydipsia anymore. We're supposed to call it primary polydipsia, and I'm not exactly sure why we do that, but you know, you're right. It is psychogenic polydipsia, but it has a new name.
I'm not so sure. There was a term called tea and toast
Tea and toast. Do you have any idea
syndrome.
what that means,
Maybe
Kiara? Okay,
it's
so tea
fine.
and toast
Low
is number
amount
2,
of
and what's number 3?
mm,
And somebody already mentioned it in the chat. A couple people mentioned in the chat. And that's beer potomania. Okay, let's go over
beer.
those and see whether any of these make sense. So what is tea and toast and beer potomania really have the same underlying physiology. So here's the idea. Periodically, you'll have someone who comes in who has gotten so hooked on alcohol that they don't eat at all and they just drink beer. In order to excrete a liter of urine, we need at least around 50 milliosms, because that's as much as we can dilute the urine. Beer doesn't have that many milliosms. So let's say you drink a liter of beer and let's say it has 25 milliosms. That means you can only get rid of half a liter of beer, half a liter of water, because you don't have enough milliosms for a whole liter. So what happens is if you keep drinking beer and you're not eating, you first use up extra osms you have and you get a little bit muscular wasted, etc. But sooner or later, you don't have the osms to donate to the urine. And it's like drinking water. And you can't get rid of the water because you don't have enough solute. And that's the same idea of tea and toast diet. These are little old ladies who sit around and sip tea all day that has almost nothing in it. And then they eat dry toast, which has almost nothing in it. And so they can't get rid of the fluid. They correct instantaneously when you feed them. In fact, too fast. That those people, if they come in with really low sodiums, are really at risk of overcorrecting. Primary polydipsia, given normal renal function, you have to drink a lot of fluid to not be able to excrete it, but you can overdo it. And there are cases, really silly, horrible stories of radio hosts who, as a sort of a prank contest, said, how many people can you drink 3 gallons of water real quickly? And people died. I mean, there are reports of that. So you can drink so much water that you drive your sodium down. This happens most commonly with schizophrenia. That people will just sit at the water fountain and drink water, and I've had some of those patients, and they'll have very low urinosms. So we have to go back. I think we can assume for a minute or two that the urinosms at 118 represent as low as he can get his urinosms. The other reason for those low urinosms would be that he no longer has ADH. because he has diabetes insipidus. And maybe because he was making so much urine, they were giving him so much fluid that they overdid the fluids. So the first thing I want to do is I want to look and see what his IV fluid rates are and what kind of fluid is he getting. Are they giving him D5.5 normal saline, which is really like giving a lot of water. And so is this a problem of his IV fluids during surgery and after surgery? Does he have a history of beer potomania? I mean, did he come in like this? But the whole story is really a strange one because the first thing we thought of is SIDH. Now, the urine pH of 9 is really weird. And I'm trying to figure out whether that helps us or not. So what could a urine pH of 9 mean? What's the first thing you think of when you see a urine pH of 9? Anybody?
I just know that it is not as acid as should be.
Okay. Urine pH of 9 makes me think of Proteus urinary tract infection. That's the first thing I think of because it's so unusual. You can get it with urease producing E. coli also, I think. Is that right, Sean? Now, could we be spilling so much bicarb? Could the patient be getting dilute IV bicarb, and that's why? So maybe the IV fluids are D5 and W with 1 amp of bicarb, because the patient, for some reason, giving bicarb. I don't know what neurosurgery does. So I really want to know the IV fluids, because I think the IV fluids have to be a real clue here. Is he drinking? Is he awake, and is he drinking? Is he eating? So we need to know all those things to try to sort this out, because this really doesn't make sense. So TJ, help us out.
Super impressed with all this discussion. Grateful to be a part of it. So again, all of this stuff was post-op in the sort of the immediate post-op period. When his sodium was noted to be decreasing, he was transferred to the neuro ICU in an attempt to try to keep his serum sodium above 135. And so they had actually started salt tabs with 3% normal saline. And to kind of round out your fluid balance analysis, they noted that his urine output was 4.5 liters in a 24-hour period.
How much fluid did he get during surgery?
Oh, I actually don't have that information for you. I'm sorry.
So this is so strange. This is so strange. Do we know what his sodium was prior to surgery?
It was normal.
It was normal. So for it to go down after surgery, he had to have gotten a lot of water in some way, because his urinosms don't make sense if it's really urinosms. The first thing I'm going to do is I'm going to repeat the urine studies, because they just don't make sense. Why is he putting up 4 liters of urine? It sounds like he has diabetes insipidus, but diabetes insipidus should cause hypernatremia. And so sodium should be high. So that's why I'm totally confused at this point. Can you answer any of those questions, or are we missing something entirely?
So I think that, another piece of information. So by the time we were consulted, it was on post-op day 7. He had been getting this therapy for that time and kind of maintaining his sodium at that. Sodium wasn't really budging, but was still having a lot of urine. He really the main thing that he reported was that he was having a lot of trouble keeping the salt tablets down due to a lot of nausea and vomiting.
Is he getting IV fluids at this point?
He's not.
He's not getting IV fluids. Is he drinking water?
He may have been, but not a significant amount.
Yeah, because you know, I guess another possibility is he could have had a hypothalamic injury, and it could have had an impact on his thirst. Can somebody help me? Surgery had to give him some kind of fluids. What medications is he on at this point?
I actually don't have his complete med list, but I promise that everything that I have for you is you're able to, I guess, reach the diagnosis and management. So I apologize. I just don't have all the information. Okay, so TJ's getting back at me for one of the days I really grilled him hard, and that is really totally fair. So if either Sabina or Kiara can help me, that would be great. But we have a dilute urine, which suggests that he's appropriately not concentrating his urine. So could he have a reset osmostat? And no matter what we do, he stays at 129. And there is a syndrome of reset osmostat that I know almost nothing about, other than that there is a syndrome of reset osmostat, and I wonder whether neurosurgery could cause that, and that he's just protecting that. And so no matter what we do, he ends up at 129. We always have to worry about the diabetes insipidus. I can't put together diabetes insipidus because then his sodium should be going up. And he's maintaining the sodium, and he's putting out a lot of urine, which seems appropriate for someone who's hyponatremic, because he's putting out dilute urine. Could it be a nephrogenic diabetes insipidus? Well, he would have to have hypercalcemia or severe hypokalemia or lithium to probably have a nephrogenic diabetes insipidus. The nausea and vomiting, it's hard to figure out post-op. Teach us something, TJ. Okay, so we were, like I said, consulted on post-op day 7. Asked for some repeat studies. The serum sodium really hadn't changed much. It was 130. The serum osms were 270. The urine sodium was in the 50s. The pH on his UA was still alkalotic, which I think was the primary giveaway. Which I think who was it that mentioned in the chat very early on? Anne Marie said something about the pH on the UA has to kind of tell us. And so the way that this was presented to me, it was presented as like a question, what is the most likely reason why salt therapy is failing to raise his serum sodium? And our choices were SIADH, inadequate PO salt intake, pseudo-hyponatremia, nausea, vomiting, and primary adrenal insufficiency. And the answer ended up being nausea, vomiting. And the key was the pH on the urinalysis. And Dr. Judd said that this case was actually represented cerebral salt wasting, which wasn't super apparent from the initial labs, which admittedly is a little unfair if you follow a schema. but the repeat lab sort of later on, after he had been getting pummeled with all this salt, shed a little bit more light. So I really appreciated learning from this case, because all the times that I have sort of a schema for hyponatremia presented to me, I feel like cerebral salt wasting sort of gets lumped in with these other diagnoses, and I never really knew anything about it. And admittedly, I didn't even know that it was controversial until I was reading up on it today for this case, and Dr. Centaur sort of hit that from the very, very beginning. But cerebral salt wasting, it's characterized by hyponatremia and extracellular fluid depletion due to inappropriate sodium wasting in the urine. And so I guess the mechanism that Dr. Judd was telling us was, this patient was just having all of this nausea, vomiting post-op, and wasn't able to, the salt tabs were, I think, exacerbating that as well. And then the hypertonic saline, all the sodium that he was getting, intravenously was binding with the bicarb in his nephrons, and was just being excreted as sodium bicarb. And I think the key for him was when he saw the pH on the urinalysis, how much bicarb was being dumped. And so their recommendation was actually just to stop the salt tabs, treat his nausea and vomiting, and volume resuscitate. And that ended up correcting his sodium. I think the tricky thing with cerebral salt wasting, I don't, Dr. Centaur will know more than me what all the smart people are saying about this diagnosis. But from what I could tell, the main thing that you want to attempt to distinguish cerebral salt wasting from is SIADH, which can be really difficult because you typically have all the same serum and urine findings as far as sodium, osmolarity, urine sodium, et cetera. But kind of the main distinguishing factor is volume depletion for cerebral salt wasting, which I think Sabina hit right from the beginning, was like, we needed to have a really good volume assessment, which admittedly can be really difficult. So, yeah.
Just to be argumentative, I'm not convinced.
Okay.
And so I'm going to have to go read more about this. And I think that's the right answer, is to go read more about this, because we felt that the patient was uvolemic. Would cerebral salt wasting cause you to have a dilute urine?
And so on the post-op day 7, when we got our repeat labs, like I said, which I think, I just probably did a poor job of organizing the presentation, but the specific gravity on his post-op day 7 urinalysis was 1.011. I don't have urine osms for that. Still had alkaline urine. I can, if you have any additional questions about it, I'm more than happy to go to Dr. Judd and seek further clarification so I can share with the group. But
well, I'm gonna do some research. What I'm concerned about, and certainly it would have been nice to have the rest of the electrolyte panel. Did he develop a metabolic alkalosis?
Yeah,
from the vomiting?
That's a great question. I'm sure he did. I don't know.
Yeah. What I'm having a hard time reconciling is, it seems like two different things were going on, and I'd love to know how much fluid he got initially, because it seems like initially he was appropriately getting rid of water. Yeah. And I don't think that's what cerebral salt wasting is, because I don't think you get a urine osm of 118 with cerebral salt wasting. That's what I'm gonna have to look up. And that's what makes this so hard to reconcile. Now, later on, when his urine specific gravity is 1.01, which is inappropriate for someone who has a sodium of 130, you could say, okay, is that just enough ADH to keep him from diluting his urine and correcting totally, or is that cerebral salt wasting? And then we have to see what the debate is the nephrologists are having. Nonetheless, I think we all learned a lot, even if we don't know the answer. And I'm gonna submit that we don't really know the answer, and I'm more than willing to argue with Judd, because I've argued with him before. Right. So Anne-Marie has looked this up, and polyuria is characteristic, but that's with increased urinosms. And so that's what doesn't make sense. So I may have to call Judd up and have a debate with him. I will have a follow-up to this, and I might even do a quick Zoom with Eric and post a sort of a post-mortem on this case, to sort of try to figure out what the thought process is, and try to figure out where we are. So Kiara, what did you learn tonight?
It's always great to learn very accurate approach, and a very amazing pearl for you is that probably there's not kind of a symptomatic hyponatremia. We always have to check if there is a sodium under 129, unless in an elderly patient. Even if there is no classic symptoms, we have to check on him because there's a very high risk for bone problems and falls. So we have to check very well.
I think it's mostly the falls. And I'll tell you a quick story. I had a guy at the VA who had recurrent beer potomania. And he comes into our service and he has a sodium of 125, and he seems a little confused and a little slow. And so we slowly correct his sodium and get him up to about 130. And I come in about 2 days later and say hello to him and says, "Doc, thank you so much. Whatever you did, it feels like a fog lifted off my brain." And that's actually what happens when someone is chronically hyponatremic. It's sort of like they think slowly, and that's probably one of the reasons they fall. Sabina, what did you get out of this?
Yeah, I would say the gait and memory problems was something I didn't know about, but also the neurogenic pulmonary edema. I haven't heard of that from hyponatremia before.
TJ, what did you get from our discussion? And now I'm going to have to learn something from Judd, because he's probably pretty smart about this stuff.
No, I think I always appreciate outpatient pearls, and so I really appreciated what you had to say about getting a patient in clinic. They're hyponatremic. What are the things that are dangerous, and the increased risk of falls in the short term with the memory and gait impact, and then I would have had no clue about the neurogenic pulmonary edema. I've never even heard of that. So really appreciate
that one. I'm sure you can look up.
Cool.
And Sean, as usual, you get the last word.
Yeah, I gotta really hop along on the neurogenic pulmonary edema, and maybe not related to this case, that there are causes of pulmonary edema that aren't just cardiac. You can have nutritional causes, and so if you see pulmonary edema, don't anchor on it's the heart.
Great, thank you all for coming. We have some really interesting stuff starting to be lined up for the next month. We're gonna have a return of hematology, return of liver disease, and we have an infectious disease case.
Ooh.